Have you ever wondered about the complexities and dilemmas faced in pediatric anesthesia management? It's a realm of medical practice that demands not just clinical acumen, but also a delicate balance of empathy, patience, and finesse. It's about navigating the narrow straits between a child's fear and a surgeon's demands, between a parent's concern and the urgency of procedure. Pediatric anesthesia is a specialized field that focuses on the preoperative, intraoperative, and postoperative anesthesia care for children from newborns to adolescents. It's an area of medicine that's constantly evolving, driven by advancements in technology, pharmacology, and our understanding of pediatric physiology and pathology. The importance of this field cannot be overstated. Anesthesia is the bridge that carries a child from the distress of ailment to the relief of recovery. It's the guardian that shields them from the pain and trauma of surgery. But this bridge is not without its challenges, and these challenges are what we call management dilemmas. Management dilemmas in pediatric anesthesia are unique situations that present anesthesiologists with complex decisions and potential complications. They're like intricate puzzles that require a deep understanding of the child's medical history, current health status, and the specific surgical procedure to be performed. These dilemmas can range from managing a premature infant who hasn't fully developed their physiological systems yet, to dealing with a runny nose, which might seem like a minor issue but can significantly impact anesthetic management. Or dealing with post-intubation croup, a potentially life-threatening complication that can occur after a child has been intubated. Other dilemmas might include managing children with chronic conditions like sickle cell disease, heart disease, or a heart murmur, each presenting its own set of challenges. And then there are genetic conditions like Down syndrome or children with a susceptibility to malignant hyperthermia, a potentially fatal reaction to certain anesthetic drugs. Lastly, we have the dilemma of managing anesthesia in children with cancer, a situation fraught with its own unique set of complexities and challenges. And so, as we commence this journey of exploration into the world of pediatric anesthesia, we hope to shed light on these dilemmas and their management. Let's dive deep into some of the prominent dilemmas faced in pediatric anesthesia. Firstly, consider the case of a premature infant. These tiny patients, who have arrived in the world before they are fully prepared, pose a unique challenge when it comes to administering anesthesia. The first hurdle lies in their immature organ development. Their lungs, heart, and liver are not yet fully formed and functional, which can significantly impact how they process and respond to anesthesia. The immature lungs may struggle with ventilation, and the underdeveloped heart may not cope well with the changes in blood pressure that can occur during anesthesia. Similarly, the liver, which plays a critical role in metabolizing drugs, may not be up to the task, leading to potentially unpredictable responses to medication. Premature infants also have a higher risk of experiencing adverse events during anesthesia due to their small size and physical fragility. This includes the risk of hypothermia, as their tiny bodies lose heat quickly. They are also more prone to blood sugar instability, which can be further exacerbated by fasting before surgery. In addition, their small size makes it more challenging to secure an airway, place an intravenous line, or monitor vital signs. The margin for error is very small, and every action needs to be taken with extreme care and precision. Unpredictable responses to medication is another significant issue. It's challenging to predict how a premature infant will react to certain drugs, as their bodies are still developing and changing rapidly. The usual doses and administration techniques might not apply, and it often requires a delicate balance to achieve the desired effect without causing harm. Finally, there are other risks associated with anesthesia in premature infants, such as potential impact on brain development, the risk of postoperative apnea, and the possibility of retinopathy of prematurity, a potentially blinding eye disorder. Clearly, premature infants present a unique set of challenges in anesthesia management. These challenges require anesthesiologists to be well-prepared, adaptable, and extremely cautious, always prioritizing the safety and well-being of these tiny patients. Another common dilemma is the seemingly innocuous runny nose. This everyday occurrence can become a complicated factor in pediatric anesthesia. A runny nose is often indicative of an underlying upper respiratory infection. This can escalate the risk of respiratory complications during anesthesia, such as bronchospasm or laryngospasm, both of which can cause significant distress and potential harm to the child. The decision-making process becomes more complex when faced with a runny nose. Anesthesiologists must weigh the urgency of the surgery against the increased risk of respiratory complications. They must consider factors like the severity of the runny nose, the presence of other symptoms, and the child's overall health status. If the decision is made to proceed, anesthesiologists must be prepared to manage potential complications. This can involve using specific techniques to minimize respiratory irritation or having a well-prepared plan for an emergency situation. A simple runny nose, thus, can pose significant dilemmas. Now let's consider the post-intubation croup. It's a potential complication of endotracheal intubation, particularly in pediatric patients. This occurs when there's inflammation and swelling in the windpipe, leading to a distinctive barking cough, stridor, and in severe cases, respiratory distress. The risk of post-intubation croup is higher in children due to their smaller airways. It's often the result of prolonged intubation or the use of an endotracheal tube that's too large for the child's airway. So, how can we prevent it? One way is by selecting the appropriate size of the endotracheal tube. It's also crucial to limit the duration of intubation as much as possible. Regular monitoring for early signs like increased respiratory effort, changes in voice, or a new onset cough can also prove beneficial. Remember, early recognition and timely management can make a significant difference. Post-intubation croup is a serious concern that requires careful management. Sickle cell disease presents another complex dilemma. This is a genetic disorder affecting the red blood cells, which carry oxygen throughout the body. In sickle cell disease, these cells become rigid and sticky, taking on a crescent or sickle shape. These misshapen cells can get stuck in small blood vessels, which can slow or block blood flow and oxygen to parts of the body. In the realm of anesthesia management, this presents several unique challenges. One of the most significant is the potential for a sickle cell crisis. This is a painful episode that can occur when the flow of blood is blocked to an area because the sickle-shaped cells have become stuck in the blood vessels. It's a serious complication that can be triggered by a variety of factors, including stress, infection, and changes in temperature, all of which can occur during a surgical procedure. Anesthesia can lower the body's temperature and reduce blood flow, which can trigger a crisis. It's a delicate balancing act to maintain the right conditions to prevent a crisis, while also ensuring the patient is adequately anesthetized for the procedure. Patients with sickle cell disease are also at an increased risk of infection. This is due to the fact that the spleen, which helps the body fight infection, often doesn't work properly in people with sickle cell disease. In the context of anesthesia management, this means taking extra precautions to prevent infection, both during and after the procedure. Other concerns include managing pain, as patients with sickle cell disease often have chronic pain in addition to acute pain during a crisis. Anesthetic drugs can also affect how much oxygen the blood can carry, which is already a problem in patients with sickle cell disease. In conclusion, the management of anesthesia in patients with sickle cell disease requires careful consideration and planning. It's a delicate balancing act, requiring a deep understanding of the disease and its complications, as well as the potential impacts of anesthetic drugs. Sickle cell disease truly complicates anesthesia management. Heart disease or heart murmurs in children add another layer of complexity. Navigating the world of pediatric anesthesia can be a tricky affair, even more so when a child has a heart disease or heart murmur. These heart conditions pose a unique set of challenges when it comes to administering anesthesia. A heart murmur, for instance, is a sound made by the blood circulating through the heart's chambers and valves, or through blood vessels near the heart. Often, heart murmurs are harmless. However, some can indicate heart problems, especially when accompanied by other symptoms of heart conditions. Children with heart disease, on the other hand, are a special group. These young ones might have congenital heart disease, heart failure, or other heart conditions that require surgical interventions. For these children, anesthesia is not just about ensuring they don't feel pain during a procedure. It's about managing their heart condition throughout the process. The potential for cardiac events is always a concern when dealing with children with heart disease or murmurs. Anesthesia can have a direct impact on the heart, affecting its rhythm, rate, and function. It can also influence blood pressure, which in turn impacts the heart's workload. Imagine the heart as an engine. Just like how an engine performs best under optimal conditions, so does the heart. Any significant changes to these conditions, such as those brought about by anesthesia, should be carefully managed. That is where the anesthesiologist's skill and expertise come into play. They must carefully balance the need for anesthesia with the potential risks it poses to the child's heart. This could mean adjusting the dose, choosing a different type of anesthesia, or even employing additional monitoring techniques. It's a delicate dance between ensuring the child is comfortable and pain-free, and ensuring their heart continues to function effectively during the procedure. In conclusion, heart disease or heart murmurs in children are not just mere medical terms. They represent a complex interplay of factors that must be carefully considered when administering anesthesia. Heart conditions demand careful consideration in anesthesia management. Next, consider the risk of malignant hyperthermia susceptibility. Malignant hyperthermia, or MH, is a severe reaction to certain drugs used during general anesthesia. It's a potentially life-threatening condition that's inherited in an autosomal dominant manner, meaning if one parent carries the gene, there's a 50% chance it could be passed on to their child. While it's relatively rare, with occurrences in about 1 in every 50,000 to 100,000 surgical procedures, it's a critical consideration in pediatric anesthesia. The first signs of MH can be subtle. A sudden, unexplained rise in end-tidal carbon dioxide, even with increased ventilation, can be a key indicator. This may be accompanied by tachycardia, a rapid heart rate, and muscle rigidity, particularly following the administration of succinylcholine. As the condition progresses, the patient may exhibit a high fever, often exceeding 104 degrees Fahrenheit. Prevention is the best strategy when it comes to malignant hyperthermia susceptibility. If a child has a known susceptibility, or if there's a family history of MH, certain anesthetic agents such as volatile anesthetic gases and the muscle relaxant succinylcholine should be avoided. Instead, safe alternatives like non-triggering anesthetic agents can be used. In the event of a suspected MH reaction, immediate action is crucial. The administration of the drug dantrolene, a muscle relaxant that counteracts the effects of MH, can be life-saving. Additionally, cooling measures, such as applying ice-cold saline and using a cooling blanket, can help bring down a dangerously high body temperature. In summary, malignant hyperthermia susceptibility is a rare but serious risk in pediatric anesthesia. By staying vigilant for signs, avoiding triggering agents in susceptible patients, and acting swiftly if a reaction is suspected, we can significantly reduce the risk and ensure the safety of our smallest patients. Malignant hyperthermia susceptibility is a pressing concern in pediatric anesthesia. Children with Down syndrome present their own unique set of challenges. Anesthetizing these children is no different, requiring careful consideration and meticulous planning. The key concern is their heightened sensitivity to certain medications, which can lead to complications if not properly managed. Down syndrome patients often have cardiac abnormalities, making them more susceptible to the effects of anesthesia. They also tend to have a narrow airway, which can make intubation more difficult. Additionally, these children may have gastroesophageal reflux, which increases the risk of aspiration during anesthesia. Furthermore, their hypotonic muscle tone can lead to challenges with positioning and airway management. They may also have an unstable atlantoaxial joint, which can lead to spinal cord compression if not carefully managed. To successfully navigate these complications, the anesthesia care team must tailor their approach. This includes careful preoperative assessment, judicious selection of anesthetic agents, meticulous airway management, and vigilant postoperative monitoring. The management of anesthesia in children with Down syndrome requires a tailored approach. Finally, let's discuss the dilemmas presented by pediatric cancer patients. Administering anesthesia to these young souls is a delicate task, brimming with complexities. The reason being, these children may already be on a variety of medications to manage their cancer, and these drugs could potentially interact with the anesthesia. Anesthesiologists must be vigilant in understanding the intricate pharmacodynamics and pharmacokinetics involved in these cases. It's a careful balancing act to ensure the anesthesia doesn't exacerbate the child's existing condition or cause unforeseen complications. Moreover, children with cancer often require frequent procedures, which means repeated exposure to anesthesia. This repetition raises concerns about potential long-term effects, particularly on a child's developing brain. It is a challenge for anesthesiologists to strike a balance between managing pain and minimizing potential risks. In essence, cancer in children presents a multitude of anesthesia management dilemmas. But with careful planning, thorough knowledge, and a gentle touch, these challenges can be effectively managed. We've covered a lot of ground today discussing the dilemmas in pediatric anesthesia management. We kicked off with the unique challenges of the premature infant, focusing on their special physiological needs. Then, we delved into more common issues like the runny nose and how it affects anesthetic procedures. From there, we explored the post-intubation croup, a potential complication that requires careful management. Sickle cell disease was our next stop, emphasizing the importance of understanding the disease's implications for anesthesia. We then navigated the complexities of heart disease or heart murmur in children, before diving into the rare but serious concern of malignant hyperthermia susceptibility. Next, we addressed Down syndrome, discussing the distinct considerations for these children, and finally, we touched on the profound challenges of managing anesthesia in pediatric cancer patients. Remember, every child is unique and presents their own set of challenges and dilemmas in anesthesia management.